Hi everyone, I'm Dr. Ye, currently an associate professor of neurology in Taipei Medical University. Today, I'll talk about a common neurological disease, stroke. I will give two talks about stroke. One is overview, the other is the management of stroke. This is my CV. These are photos taken when I visited to Kingdom of Eswatini in 2019. That time, I joined the Taiwan Medical Mission to teach neurological examination and the introduction of common neurological diseases. I was very lucky to have chance to pictured with His Majesty in the Butimba Royal Hunting Ceremony in the August 2019. These are photos when I gave lecture in Mababani Government Hospital. I enjoy a great time and hope I can be there with you guys next year. This is the outline. We can define the stroke according to the duration of neurological deficits. Acute stroke represents sudden onset for neurological deficits due to vascular etiology, onset within 2 weeks. The transient ischemic attack TIA is the neurological deficit occurs prompt and complete recovery within 24 hours. Vertebral basilar insufficiency VBI is also prompt and complete recovery within 72 hours. Reversible ischemic neurological deficit RIND is slower but complete recovery 1 day to 3 weeks. Complete stroke represents incomplete or absent recovery with permanent deficit. According to a report comparing the data from 1990 to 2013, stroke, both ischemic stroke and hemorrhagic stroke, give a significant burden in the world. The death incidence prevalence all increased in 1.3 to 1.8-fold for either ischemic or hemorrhagic stroke in the 13-year period. Among these cases, 70% were ischemic stroke, while 30% were hemorrhagic stroke. There are more than 6 million deaths and caused by either ischemic or hemorrhagic stroke in 2013. The disability adjusted life years are 10 years per each stroke patient. In Taiwan, stroke is the first 3 leading cause of death for more than 30 years. The prevalence was 16.4 per 1,000 population aged older than 35 years. The incidence was 300 to 500 per 100,000 population aged older than 35 years. The male to female ratio is approximately 2 to 1. From the Taiwan Ministry of Health and Welfare's data, stroke has been the first leading cause of death in 1980s. In contrast to the rapid growing of cancer, the death of stroke gradually drops following the time. It is partly owing to the risk factors control and education. Let's take a look on the top 10 causes of death in Eswatini from WHO's data. The number in red is Taiwan's data for comparison. In the past 20 years, HIV infection AIDS is still the leading cause of death in Eswatini. From 2000 to 2019, stroke raised from 5th to 4th position of leading cause of death. The deaths increased from 64.2 per 100,000 population in 2000 to 91.4 in 2010, then returned to 69.7 per 100,000 population in 2019, compared with 51.6 per 100,000 population in Taiwan. The life expectancy also increased from 49 years in 2000 to 59 years in 2019. Similar to Taiwan, there is a gender difference on the leading cause of death in Eswatini. For men, stroke raised from 6th position to 5th position in 2019, while for women, stroke raised from 4th position to 2nd position in 2019. Simply, we can separate stroke into two types: ischemic stroke and hemorrhagic stroke. Ischemic stroke is caused by obstruction of blood flow resulting in a blood-deprived area. We can see a low-density dark area on the brain CT image. Hemorrhagic stroke is caused by leaking blood into brain from a ruptured blood vessel, resulting in a bleeding area. We can see a high-density bright area on the brain CT image. Ischemic stroke accounts for 70 to 85% of cases. The etiology of ischemia can be global hypotension due to circulation arrest, shock condition, or hypoxic, emboli due to cardiac origin or intra-arterial, thrombosis due to occlusion of small penetrating arteries or large vessels. Intracerebral hemorrhage accounts for 10 to 30% of stroke patients. Most of them are related to hypertension, breathing disorder, trauma, angiopathy, or drugs. Subarachnoid hemorrhage accounts for 5% of cases, resulting from aneurism of AVN. From a Taiwan study published in Journal of Stroke in 2014, the cause of stroke in Taiwan, 73.9% are ischemic stroke, 6.7% are transient ischemic attack, 16% are hemorrhagic stroke, and 2.8% are subarachnoid hemorrhage. In the ischemic stroke, the etiology is small vessel in 37%, large vessel in 27%, cardiogenic in 11%. Different to Western countries, large vessel account for 40% of stroke cases. The main cause of ischemic stroke is atherosclerosis. Atherosclerosis typically begins in early adolescence and is found in asymptomatic and remains undetected by most diagnostic methods. Endothelial dysfunction is a systemic pathologic state of the endothelium. If you have too many cholesterol particles in your blood, cholesterol may accumulate on your artery walls. Eventually, deposits called plaques may form. The deposits may narrow or block your arteries. These plaques can also burst, causing a blood clot to form. Epithelial mesenchymal transition is an important mechanism of atherosclerosis. At areas of disturbed blood flow, endothelial cells are activated and the adherent junctions dissociate, resulting in lipid accumulation in the vessel wall. Those are the mechanisms recruit of inflammatory cell, foam cell formation, and adventitious smooth muscle cell proliferation contribute to plaque progression. The pathophysiology of cerebral ischemia and the infarction involve vascular and metabolic factors. The normal perfusion of brain is 50 to 60 milliliter per 100 gram per minute. The benign oligemia is 35 to 50. The brain cells are still safe. Irreversible cell death occurs when perfusion drops to below 10 milliliter per 100 gram per minute. This area will become infarct. When the perfusion drops to below 35 milliliter, protein synthesis ceases. The following by disruption of synaptic transmission, the cerebral ischemic results in release excitatory neurotransmitter such as glutamate, aspartate, increase the intracellular influx of sodium and calcium, ATP depletion, lactate accumulation, and subsequently the injuries to oligodendroglial cell and endothelial induced inflammatory change and cell death. The area of perfusion and diffusion abnormality are called penumbra. To save the penumbra and reduce infarct area is the primary goal of acute management of newly onset ischemic stroke. There are different temporal patterns of common neurological disease. When a disease happens suddenly, reach maximal neurological sign and symptom within seconds to minutes but resolve fast, the possibility causes are seizure or transient ischemic attack. For the acute onset, symptoms occur within minutes to hours. This can be stroke. The clinical cause is helpful to differentiate different etiologies of stroke. For thrombosis, the neurological deficit can be mild initially, then progress to the maximum in several hours. Embolic stroke is usually caused by the emboli. The neurological deficit reaches to maximum soon owing to the blood occlude the major artery, but the symptoms and signs recover or even return to normal if the clot is dissolved by intrinsic thrombolytic mechanism or given intravenous RTPA. Intracerebral hemorrhage usually occur while doing activity. Most of them are related to hypertension. The neurological deficit caused by hematoma occur rapidly and persist following the time. This is a planned CT of head. The important structure and the landmark are shown in the figure, including the brainstem, pons, midbrain level, and the thalamus, basal ganglia, and corona radiata, and the semi-ovale. The brain is supplied by 4 neck vessels, 2 carotid arteries, and 2 vertebral arteries. The common carotid artery bifurcates at the C4 level. The common carotid artery stenosis is often at the orifice. The axonotmatous plaque in left side is more prevalent than right side. In patients having received radiation therapy for nasopharyngeal carcinoma or other cancer, the stenosis is usually at the mid-portion of common carotid artery. The internal carotid artery stenosis occur most common above bifurcation. There are silent stenosis or occlusion in 1/3 of cases. The mechanisms of stroke in ICA stenosis occlusion are artery-to-artery embolism or watershed ischemia due to hypoperfusion. The size of carotid artery stroke depends on the adequacy of collateral flow. It can be ACA territory infarction, PCA infarction if there is a fetal type PCA, or watershed infarction. Amaurosis field gas is monocular biagnys, which can be seen in carotid artery stroke and is present in 10 to 25% of symptomatic carotid stenosis. This is a schematic representation of progression of visual disturbance in amaurosis field gas patient following the time. Large emboli from heart go to NCA, while smaller emboli from carotid artery may be preferentially carried to ophthalmic arteries. The hemispheric TIA can be due to emboli or hypoperfusion. Headache is also a common symptom, usually above the eyebrow in carotid thrombosis, at temporal in NCA occlusion, or behind the eye in PCA occlusion. The NCA arises from the internal carotid artery and continue into the lateral sulcus when it then branches and projects to many parts of the lateral cerebral cortex. It also supplies blood to the anterior temporal lobe and the insular cortex. The occlusion of NCA results in middle cerebral artery syndrome, potentially showing the following deficit: paralysis or weakness of the contralateral face and arm, sensory loss of the contralateral face and arm, damage to the dominant hemisphere result in aphasia, damage to the non-dominant hemisphere result in contralateral neglect syndrome and visual spatial dysfunction. Large acute dementia in fact often have eyes deviated toward the side of the lesion. Contralateral homonymous hemianatopia and altered consciousness can appear. This is a case presentation of large NCA infarction. A 55-year-old right-handed accountant presents with confusion, sleep problem, and trouble at work. There's a mild decrease at light touch in her right arm, unable to distinguish finger from thumbs, really can write clearly, but speech is intact. The two anterior cerebral arteries arise from the internal carotid artery and are the part of the circle of Willis. The left and right anterior cerebral arteries are connected by the anterior communicating artery. The ACA supplies most midline portions of the frontal lobes and the superior medial parietal of the brain. Anterior cerebral artery syndrome is characterized by weakness and sensory loss in the lower leg and the foot opposite to the lesion and the behavioral change. This is a case presentation on left ACA infarction. The posterior cerebral artery syndrome supply the occipital lobe. The two arteries originate from the distal end of the basilar artery, where it bifurcates into the left and the right posterior cerebral arteries. The PCA anastomosed with the middle cerebral artery and the internal carotid arteries with the posterior communicating arteries. The posterior cerebral artery stroke syndrome can present with contralateral homonymous hemianopia, cortical blindness with bilateral involvement of the occipital lobe branch, visual agnosia, prosopagnosia, dyslexia, anomic aphasia, color naming, and discrimination problem. This is a case presentation of the left PCA infarction. This is the blood supply of the brain. The middle cerebral artery is one of the three major paired arteries that supply most part of the cerebrum. Watershed or borderline infarction happens when there is a generalized reduction in blood flow and the area at the edge of any territory will get the least blood supply. The watershed infarction can be classified as cortical watershed infarction (CWI), internal watershed infarction, and a mixed type. The CWI include anterior watershed infarction between ACA and the NCA, posterior watershed infarction between NCA and the PCA, and both type. The IWI consists of partial IWI and confluent IWI. The cause may be global drop in blood pressure during sepsis or other causes of shock during surgery, or an occluded or critically stenotic ICA which supply ACA and the NCA, and so that this is where infarction is worst. The important issue is that the cause may be significantly proximal to the infarct, such as severely stenotic carotid or systemic hypotension. Lacunar ischemic stroke is a recent small infarct less than 1.5 cm diameter in the white matter, basal ganglia, pons, or brainstem, and is consistent with a lacunar clinical syndrome. It is commonly attributed to an abnormality in a single small deep perforating artery, such as lenticular striate artery. These arteries are particularly vulnerable to arterial hypertension, which cause fibrinoid degeneration and microannealings of the vessel wall, and resulting in narrowing of arteries, causing lacunar ischemic infarct or rupture of microannealin, causing intracerebral hemorrhage. Lacunar stroke is a small artery disease. The etiology is 90% due to chronic hypertension or other atherosclerotic risk factors, 10% due to large artery occlusion at the origin of perforator or emboli. The pathology includes small vessel disease with lipohyalinosis, microatheroma, large vessel disease with extension of clot in many arteries, emboli, multiple new infarct in different vascular territories. There are several types of lacunar syndrome. Pure motor stroke is the most common one, accounts for 1/3 to half of cases. The location of infarct is in the posterior limb of internal capsule or basis pontis, presenting with hemiparesis, dysarthria, and dysphagia. The second common is ataxic hemiparesis. The location is in posterior limb of internal capsule, basis pontis, or corona radiata, presenting with cerebellar and the motor symptom, with more affected in the leg than arm. The dysarthria complete hand syndrome, the location is in basis pondis, presenting with dysarthria and condylosis of hand. Pure sensory stroke, the location is in contralateral thalamus, VPL, presenting with numbness, tingling, pain, or burning. Mixed sensory motor stroke, the location is in thalamus and adjacent posterior internal capsule, presenting with hemiparesis or hemiplegia plus ipsilateral sensory impairment. On MRI, an acute lacunar infarct is shown as hyperintense on DWI, hyperintense on ADC, hyperintense on T2 wet image and flare, hyperintense on T1, and hypoattenuated on CT. The high signal on DWI and flare image of acute lacunar infarct may disappear in 10% of cases after 1 year. Looks like a white matter hyperintense lesion in 30 to 80% of cases, and a cavitate in 20 to 90% of cases after 1 year. This is a slit sign represent in case after intracerebral hemorrhage several months later. For intracerebral hemorrhage, there are 35% occur in putamen, 20% in thalamus, 20% in white matter, 15% in brainstem, and 10% in cerebellum. The symptoms can range from headache, decreased consciousness, to coma. Hypertension results in the formation of microaneurysm in parenchymal artery, such as lentil striate arteries. Rupture of those microaneurysms results in intracerebral hemorrhage. The CT scan demonstrates the evolution of hematoma. The acute stage, hours to 3 days, the hematoma is hyperdense. In subacute stage, several days to 2 weeks, there's a perilesional edema develops and the progressive loss of density. Then isodense in late subacute stage. In chronic stage, over 3 weeks, it becomes mildly hypodense. The risk factors of ischemic stroke include major risk factors: old age greater than 65 years old, hypertension, diabetes, heart disease, and the previous TIA or stroke. The minor risk factors include smoking, alcohol, hyperlipidemia, polycythemia, obesity, immobility, family history, drugs such as hormone combined contraceptives, and a recent infection. Recently, atrial fibrillation has been noticed as an important stroke risk factor. In Western countries, US, Iceland, or UK, atrial fibrillation increased 5.6 to 7-fold risk for stroke. In Taiwan, is 3.87-fold risk for stroke. Atrial fibrillation is closely related to atherosclerosis. The local hemodynamic disorder caused by AF may cause the damage of the carotid endothelium by the shearing force of abnormal blood flow, which may eventually lead to the formation of carotid artery abnormality, including plaque, atherosclerosis, and stenosis. The risk of LA thrombosis increase in paroxysmal AF patients and get worse in persistent AF patients. The predictor is CHA2 DS2 VASC score, and the duration of atrial fibrillation. Anticoagulant therapy based on the CHA2 DS2 VASC score is now the mainstay of management of patients with various types of AF in order to prevent thromboembolic events. The score consists of several items: congestive heart failure, hypertension, age greater than 75, diabetes mellitus, stroke, vascular disease, age, and sex. The score is highly correlated with the annual stroke risk, so it now becomes a guideline of management of patients with atrial fibrillation in order to prevent thromboembolic events. However, there are some difficulty in patients with warfarin therapy. The optimal therapeutic window for PT-INR is between 2 to 3. Under-treatment is ineffective, but over-treatment may result in serious intracranial hemorrhage. Fortunately, there are several direct oral anticoagulants in the market in recent years. Those are effective for reducing the risk of stroke and significantly less hemorrhagic events compared with warfarin. Dr. Akinyemi has just published an article regarding to stroke in Africa on October issue of Nature Review Neurology. From 2 studies, SIREN and regards hypertension and dyslipidemia are the major stroke risk factor in all Africans. The third one is diabetes for indigenous Africans, obesity for African Americans, or alcohol for Americans of European descent. Compared with Interstroke Africa and the SIREN data, hypertension, dyslipidemia, and obesity are 3 major risk factors for stroke, whereas healthy high vegetable diet and regular exercise are protective factors for stroke, indicating the lifestyle modification is important for stroke prevention. The prevention of stroke includes primary prevention, consists of hypertension treatment, anticoagulation for atrial fibrillation, lifestyle, especially stopping smoking, starting use, and the influenza vaccination. The secondary prevention for ischemic stroke include blood pressure and cholesterol-lowering agent, anticoagulation for atrial fibrillation, lifestyle, especially stop smoking, antiplatelet therapy, influenza vaccination, and carotid endarterectomy or stenting for symptomatic carotid stenosis patient. The secondary prevention for hemorrhagic stroke include blood pressure lowering, lifestyle, avoid antithrombotics, and influenza vaccination. The optimizing stroke care requires several domains: epidemiological surveillance, including burden, trends, cause, and risk factors. The aim is to provide evidence for planning and designing interventions. The health promotion and disease prevention, including primordial, primary, and secondary, aim to reduce incidence and the prevalence of stroke. Acute stroke care includes early and accurate diagnosis and presentation, pharmacological and non-pharmacological treatment prognostication to aim to reduce mortality, and the rehabilitation aim to reduce disability and improve health-related quality of life. Remember that the hallmark of all stroke syndrome is sudden onset, reaching maximal severity of symptoms usually very quickly. Different presentations in different stroke types and location, and the prompt identification and management to save the brain, and seeking stroke risk factor and prevention are important. And we need a multidisciplinary care for good stroke care. Thank you for your listening.